Dear members and supporters of OcuMel, this is Heinrich Heimann speaking. I'm one of the consultants at the Liverpool Ocular Oncology Service, and my talk today is on the radiation side effects on the retina, including radiation maculopathy, which is important for a lot of patients and plays a big role in our daily treatment and management of the patients during the follow-up. Now, the radiation effects on the eye have to be thought of. If this is a small melanoma here at the back of the eye, the radiation obviously aims to destroy the tumor, but it will also affect the healthy tissue surrounding the tumor. There's no way we can stop that, so we always have to think we're not only destroying the tumor cells selectively, but the healthy cells of the retina around it will die. And as it is in this case, sometimes they're the very vital structures that you need for good vision in that affected eye. So we can see that this patient underwent proton beam radiotherapy, and you can see the treatment plan here. And what you see, these rings are the concentration or the energy of the proton beam in various areas. We try to treat the tumor with the radiation that is required to destroy it, but at the same time we try to minimize the radiation to the surrounding tissues. You can see it here. If you think of the proton beam entering the eye coming from the side into the eye, it will hit quite a bit of retina on its way to the choroid at the back of the eye where the tumor is. You can see that here in the rings that are painted onto the picture. The red one is the 100% ring where 100% of the required energy will be focused. This is surrounding the tumor and a millimeter or two surrounding the tumor. But you will also see the 50 and 20% rings there. The blue one is the 50% dose of radiation. And you can see that quite a large area of the retina, from the front to the back, will receive that type of radiation, and therefore, unfortunately, has a risk of being damaged by the radiotherapy as well. Now, in the beginning, we have to talk a little bit about the anatomy of the eye and what structures are important, because it's not quite that easy to understand. So again, you have a tumor relatively close to the back of the eye. It's in the choroid. That's the layer underlying the retina. The retina itself is like the wallpaper inside the eye, and this is like the chip of the camera or the film of the camera. This is the part that really changes light into electric energy that our brain will see as pictures and light and vision. The choroid is the layer underneath it. This is where most of the melanomas will occur. And this is comparing it to a 5p coin. This is the back of a 5p coin. This is at the back of the eye. So what is often sort of not quite understood, this is your whole retina here. Obviously the whole retina has photoreceptors and can see light. But really important for your vision is only this part at the back of the eye called the macula. And really, really important is only this part of the eye called the fovea. This is your point of best vision, like a bullseye of a dartboard. This is the only part of the retina that has enough vision to read and recognize faces. So the whole rest of the retina can see light, but only shapes and movements. This is the optic nerve head at the back of the eye. This is where all the nerve cells and nerve fibers from the retina are bundled into one cable connecting the eye to the brain. So that's quite an important structure as well, because all the cabling of the retina goes through there, and damage to this part damages the cable and damages the transmission. Everything that's been acquired in the retina has then been damaged and cannot be transmitted to the brain. So again, to recap, the macula is the central part of the retina, approximately 8 to 10 millimeters. That is important for your vision. When you walk around, you need the macula. When you look at faces, you need it. This is where really most of the vision is. And the very most important part is the fovea. This is where your reading ability is in recognizing faces and colors. This is only playing in this very small spot here in the center of your retina. And this is the optic nerve at the connection to the brain. Now we have the photography, but you probably from all the clinics know that there's a second type of imaging that we now do routinely. That's called an OCT scan. And that picks up slices, basically like a slice of cake, through your retina and shows it from the side. So this is an OCT scan through your middle of the retina, and we can distinguish the fovea. This is the very thin part. All these cells are pushed to the side, so all the light can enter the fovea and get the best image possible. So it's thinner normally, as you see in this scan. And this is the macula. This is the important part of the retina for your vision in one slice. You can get many slices up and down in the macula, but usually when you show it at conferences or when you're in clinic, you show your fovea, it's a slice right through the middle, through your fovea and macula. So if we treat a tumor, like again this melanoma, slightly to the side of the macula, our aim is to destroy the tumor with adequate safety. This is our #1 priority. But at the same time, we try to minimize the damage to important retinal structures. So every treatment plan, every treatment decision, whether we use a plaque or proton beam or whatever type of radiotherapy, will have the same aims: destroy the tumor with safety, but limit the damage to the healthy tissue surrounding it. So for instance, the plaque radiotherapy here will destroy the tumor. So this is the patient undergoing plaque radiotherapy before the treatment. And you can see some months after the treatment, the tumor is smaller, but you can see around it a scar developing. This is like the footprint of the plaque. This is where the plaque was. It does not only destroy the tumor, but it also destroys the retinal tissue in that area. And you can see that. So that's a scar. So we know exactly where the plaque was afterwards. And you can see it sometime afterwards. This is where the plaque was, and you can see the scar. And sometimes afterwards, you can see there's a complete flattening of the tumor and the scar from the plaque. And in this case, it worked the way we wanted to. All the tumor has been covered, all the tumor has been treated safely, but at the same time, the scar does not extend into the macula and the fovea, just the edge of the macula. But if everything goes well, this patient has the tumor treated safely, but the central vision remains intact. So when you come for a follow-up examination, we basically look at two different things. #1 is the tumor, and that's the most important one. So we check every tumor for a regression, meaning is all of the tumor gone or is it smaller compared to the previous examinations? Some tumors never go away completely, so you're left with a scar. You can see them on the pictures, which for instance after proton beam radiotherapy is quite common, that they don't go away completely. Plaque radiotherapy has a higher radiation energy, and we more commonly see that the tumor goes away completely, and you can see a better scar. So that's one thing, and we look for potential recurrence. Is there any edge on the side or perhaps outside the eye that we can't see from the inside? We use the ultrasound for that. Is there any sign of the tumor coming back in the eye? So that's one part of the routine examination during the follow-up. But the other part looks at the potential damage to the healthy tissues, to the retina. So we look for radiation retinopathy. We check for that by looking into the eye, and there can be various stages. It could be that there's no retinopathy, no signs of any damage to the retina. It could be that we see mild signs of retinal damage from the radiotherapy, and probably won't even tell you that because they're just signs that don't have any clinical meaning. But there is then a threshold where it's getting more serious, where it can have an effect on vision. And this is the maculopathy, meaning the retinal damage affects the macula and your point of really important vision in the macula. We always look for that. We always look for optic neuropathy, meaning could there be radiation damage to your optic nerve as well. And finally, the worst stage, fortunately only in about 5 or 10% of the patients, is what's called proliferative radiation retinopathy. This is the end stage. As I said, 95% of patients will never get there, so we're not worried about that, but about 5 to 10% will develop proliferative radiation retinopathy, the more serious stage of the disease, and I'll come to that in a minute. So what exactly is happening in the retina when we have radiation damage? Now, this is a patient with a small melanoma right in the macula and under the fovea. So we know that if we put radiotherapy on the eye, the retina will get damaged. But the retina itself, actually, it's what's called a post-mitotic tissue, meaning these cells will not divide anymore. All your retinal nerve cells that you had them when you were born, really. and they don't sort of proliferate afterwards. So whatever you see now during this presentation, it's the same photoreceptor you had as a 5-year-old. They don't multiply, and unfortunately that means when they get damaged, there's no second set or so. Unfortunately, every retinal cell that's damaged, it's gone. But that's of advantage regarding radiotherapy, because radiotherapy works very well against dividing cells. So the typical side effects of radiotherapy outside the eye that you will know is hair loss, or because the hair cells will divide and they get damaged by the radiotherapy, or that you get more infections because the blood cells, your white blood cells, divide a lot and they get damaged by radiotherapy, so you have less white blood cells and you get more infections. Or in your guts, these cells divide a lot, and if you get radiotherapy to this area, you will have problems there. So these are typical radiation problems, and the retina is exactly the opposite. The retina cells are they're set in stone, so to say, they don't divide, so the retina itself, the photoreceptors, they're not very sensitive to radiotherapy. But the cells that are sensitive to radiotherapy in the eye are the blood cells, because they, and the blood vessel cells, because they will continue to divide over time. So the most important damage of the radiotherapy to the retina is actually the damage to the retinal blood cells. And the renewal cycles of these cells is about 18-24 months. And this is why you don't get the immediate radiation retinopathy effects in the weeks after the radiotherapy. You usually have them with a delay of about 1.5 to 2 years after the treatment. On the one hand, that's quite good. You've got quite a good period, usually after treatment, for instance, after proton beam, where not much will happen to the vision. But then there can be a second wave of problems, and that's usually 1.5 to 2 after the treatment. And this is why we cannot discharge patients after 6 weeks or so, because a lot of the complications and problems develop between year 1 and 3 after the treatment. And the damaged blood vessels, that's the major problem. They leak fluid into the retina. So all the blood vessels you see on this picture in the retina, they are quite tight. They don't have much leakage. But once they're damaged, they leak a lot of fluid into the retina surrounding the tissue. And in the worst stage, not only will they leak and get damaged, but as a reaction of the body, new blood vessels will grow into the eye. That's the proliferative stage. So this patient here, after 18 months, you can see the retina changing. It looks completely different to what it was before. And this is when it all kicks in. And I'll show you more pictures how that developed some months later, looking different. Now more blood you can see in the eye and other changes, and I'll come to that in greater detail. And finally, the worst stage, this is the proliferative stage. So what are the clinical signs? So what may you hear from us when you come for follow-up following the radiotherapy? Now, the early signs are hemorrhages or little bleedings into the retina. They're not significant. They don't cause any harm. They're just a sign for us to say, oh, there's some radiation damage. So that's not much we need to do about that. It's just a clinical sign. And the second one are these yellow packages of material there. What is that? These are called cotton wool spots, and they're microinfarcts in the nerve layers of the retina. So like little strokes or little heart attacks in the retina. Again, because they're so small, they usually don't cause any harm that you would notice, and they don't need any treatment, but they're a sign for us the radiation has hit the retina, and there is some radiation damage to be expected probably in the future as well. And if you look on the picture on the right, this is then the next step of what can happen. This is on the left, radiation retinopathy. This is the mild or early stage. It does not need any treatment, and it doesn't cause any problems really. But these are the more advanced stages. You can see these white blood vessels. They're not filled with blood anymore. They're called ghost vessels. So this is that these blood vessels have been severely damaged. They can't do what they need to do, get blood to the retina and get it back again. That's not possible. And you see these yellow exudates, they're called. This is a sign of severely damaged blood vessels. They're leaking fluid into the retina. Usually the retina is like a dry sheet of paper, and if you see these yellow exudates, you know it's like a sponge more. It's full of water, like a carpet flooded with water really, and then the retina doesn't work anymore. So these are called exudates. And then you have radiation maculopathy. As we discussed before, the macula is very important here in the blue circle. So if any of the fluid, these exudates, affect the macula, that's got the special term of radiation maculopathy then. Okay. The final step, and in this patient then, is the proliferative stage. As I said, fortunately 90–95% will never get to that stage, but 5% do, and we need to be aware of that because that does need treatment. And the clinical signs are, these are new blood vessels growing into the eye. Basically, the retina doesn't get enough blood, and it triggers new blood vessels to grow, which is a great idea, but they're badly made, and they grow into the eye, and they can bleed, and they can lead to a retinal detachment or increase the pressure in the eye, and they cause all sorts of problems, and they do need urgent treatment. That's proliferative radiation retinopathy. And then there is another particular sign on the optic nerve head, usually only in tumors that are at the optic nerve head. That means if we want to treat the tumor sufficiently, we need to include the optic nerve head into the field of radiotherapy, and that can lead to a swelling of the optic nerve head with bleeding, and you see these cotton wool spots as well. So if that happens, the swelling of the optic nerve following radiation treatment, that's called a radiation optic neuropathy. So what's causing all of these? There are basically three different factors, and in each patient it may be a little bit different, and we can't really say which is the most important one for each patient, but at the moment we think it's a combination of three different factors. Number one, it can be a direct hit from radiotherapy. So let's go back to this case where the tumor is at the back of the eye. You would have to radiate the central retina, and all of these structures would have got some radiotherapy, and that can damage these cells. The second are the indirect effects. So what can happen is that some parts of the retina, as a consequence of the damage to the blood vessels, will not get enough blood, and this is called ischemia. So you can see that in this area, this retina here will not get enough blood anymore because the blood vessels are damaged. And as a consequence, if the retina does not get enough blood, it starts to produce a factor, and that's quite important nowadays. That factor, or like a growth hormone, is called VEGF, vascular endothelial growth factor. So the retina produces that factor, and that factor has two major effects on the retina. Number one, it lets blood vessels leak. So normally, as I said, the blood vessels in the retina are quite tight. But if VEGF is in the eye in higher concentration, it will open the ports like a rusty pipe, so that will leak fluid. And the second effect of VEGF on the retina is, it is that growth factor that triggers the growth of new blood vessels. So the two bad effects are connected to this growth factor in the eye. But there's a third factor that influences all of this, and this is that almost always after treatment there is some bit of dead tumor left in the eye. That needs to go somewhere, so the white blood cells will attack it and try to put it away. It will cause an inflammation, and the dead tumor cells will produce still some kind of toxins or poison for the eye. In this case, there won't be much because it's just a small tumor there. The larger the tumor, the more toxins you produce, but that's another factor that causes inflammation, and that plays also a part in the development of radiation retinopathy. So what are the consequences of all of these changes? Number one, the ischemic retina that doesn't get enough blood, it won't function no more. So this retina down here, it's dead. It will not see anymore. Now, fortunately, this part is a bit on the outside, so that will be the retina looking up somewhere in the sky. So if that is gone, it's not too important for your vision. But if it affects the center, it will be very important. And unfortunately, it's not reversible. Once these blood cells are dead and don't produce, don't transport any blood anymore, they won't come back anymore. They won't regrow. The second effect is this fluid there, the wet retina, or called edema or exudates, that will not work as well. It will work, but not as well as before. Sometimes that's reversible. I'll come to that, the treatment methods, but the location is the key. So if you imagine that wet retina here, it's not very important. You won't feel much of a problem there. However, if the edema or the maculopathy extends into the macula there, into the center of your vision, then it is a problem. The location is the problem. So what happens if you get new blood vessels? Now, that can cause all sorts of problems. You can see they're bleeding already into the eye, not only in front of the disc, but also in the vitreous, and the whole eye is filled with blood, and they can cause a retinal attachment and a high pressure in the eye. If that happens, urgent treatment is required. It is reversible, but only in a short period of time. You need to get into the treatment very straight with laser and with surgery, otherwise the eye is lost. So, when does radiation retinopathy matter? So that's quite important to understand. Not all radiation retinopathy is dangerous and needs treatment. So if you have no retinopathy, only mild retinopathy, it doesn't matter much really. So if some doctors say, oh, there are new hemorrhages or cotton wool spots, that doesn't have to be a major problem. It's an indication or a warning sign that something else could happen in the future, but in a lot of cases it does not need any active treatment. An observation only is required. However, if you have one of these, maculopathy, optic neuropathy, or proliferative retinopathy, that can significantly lower the vision, and then treatment, if possible, makes sense. Then we should do the treatment. Not everybody needs treatment, and I'll come to that, but if it makes sense, if it sort of has a good prognosis, then definitely treatment is possible and should be undertaken. What are the risk factors for developing retinopathy? Now that depends on the tumor and the location, the size, and where it is in the eye really. The closer you are to the fovea and macula or to your optic nerve head, the higher the risk of getting retinopathy. So a small tumor next to the optic nerve head has quite a high risk of developing retinopathy, whereas a medium-sized tumor on the outside, not too high a risk really. So the proximity to your central vital structures in the retina is quite important. Very important is the size of the tumor, how thick it is and how wide it is really. So in various ways. Number one, larger tumors need more radiation energy, so you get more radiation into the eye. A larger area is irradiated, so more retina can be destroyed, producing more VEGF and causing more problems. And you have a larger remnant of that dead tumor for a while in the eye that causes more inflammation and can produce more poison and toxin for the eye. Other risk factors are the age of the patients, and actually younger patients have a higher risk. They have better chances of healing themselves, in inverted commas, more active tissue, more proliferation. So a younger age is associated with a higher risk of developing radiation retinopathy problems. And other factors that affect your blood vessels, and in particular if you have diabetes or high blood pressure. So if you have radiotherapy, it is quite important to have the blood pressure controlled. If it is out of control, you've got a much higher risk of developing all these problems, the vascular problems in the eye. So how can we prevent it? Can we do anything not to get or to lower the risk of radiation retinopathy? As we said, in every case, every ocular oncologist tries to minimize radiation energy, in particular the energy applied to the macula and the disc. So instead of treating this tumor with a broad beam, a blunderbuss approach, we would strive to localize the energy on the tumor only and try not to put too much radiation energy onto the fovea, the macula, or the optic disc. What you can do as a preventive measure, what has been done, is you can inject an anti-VEGF blocker. These are substances now available that you can inject inside the eye, and has been proven that they lower the risk of developing these complications. But it comes at a price because you need to be injected regularly. One injection inside the eye is not enough. It needs the injections every 4 weeks, 6 weeks. For how long? Nobody knows. Probably a year or two really to lower the risk, or even longer than that. And in very high-risk cases, what we do, and you might have heard it in some cases of our treatment, in particular after proton beam, we do a laser treatment called TTT. So that is a laser over the surface of the tumor that creates like a raincoat. So we want to stop the tumor from leaking toxins under the retina, and we don't do it in everyone, just in selected cases at a high risk. So what are the consequences of really clinically significant radiation effects on the eye? You can see here, this is the patient 12 months after proton beam of a tumor near the disc. You can see the early signs, some little hemorrhages close to the tumor. That doesn't need any treatment, but we know there's a risk of something developing. And in the right picture, you can see the exudates. They are now affecting the macula. So this patient developed radiation maculopathy with a drop in vision. And we can confirm that with OCT examinations, where we can see that this is the normal OCT, and in this particular case, taken from there, you can see the swelling. So there's a lot of fluid in the retina, it's ballooned up, and it doesn't work that well. That can happen if the tumor is close to the retina, to the retinal center, but also if it's away from it. Look at this patient, it's got a melanoma in front of the eye. You can see like the tip of the iceberg in the anterior chamber, and this has been treated with proton beam, an excellent response of the tumor to the treatment. Tumor is basically gone, but way, way behind the tumor at the back of the eye, and there was no proton beam to the back of the eye, the patient developed a macular edema. So what are the clinical signs of that? Symptoms usually are that you have a loss in vision, your vision's just fuzzier, you can't read anymore, for instance. You develop metamorphopsia. This is the medical term for straight lines not being straight. So usually the faces look a bit disturbed and like these mirrors at a fairground. So this is what some patients notice, or they have problems reading with the eye. And colors are a bit dull. Red is not as red and green is not as green as it used to be. How can you monitor for that at home? You can't go to an eye hospital every week. There are good measures today. Always cover one eye when you do these tests, and correct for your reading correction if it's in the reading distance. There are very good apps now for your mobile phone, free eye tests that you can get and download. If you want a more conservative one and live in the analog world, just get a sheet of paper with different sizes of print on it, like this one, for instance, and just cover your other eye and see what you can read once a week. Pick the smallest print you can just about read and just compare it each week, whether you can still read that or whether you need to switch to another one that's larger, really. Can we treat radiation maculopathy? And this has been a major development over the past years. So you can now treat it. This is the patient I showed before. You can treat it with laser, but that's not very successful. It makes your pictures better, but your vision doesn't really improve. So we really rarely treat it with laser, but it was the first treatment where something could be done. But this patient looked before and after with all the fluid being squeezed out of the eye like a miracle. That's been caused by anti-VEGF treatment, this one with Avastin. So we can block this growth factor that's responsible for the leakage and the growth of new blood vessels, VEGF, with an antibody. And that's been used for treatment of macular degeneration and diabetic maculopathy, similar diseases, different causes, but it works just the same in most cases of radiation maculopathy. The disadvantage is that drug needs to be injected into the eye. We don't have any eye drops of that as yet. And it works for only approximately 6 weeks, so we have to repeat it. And the biggest sort of concern over the past years is we thought that this disease would burn out and fizzle out, but it doesn't really. You need an ongoing treatment for most cases. So unfortunately, if it is successful, it means that we need to keep on injecting. We try to make the treatment intervals longer and longer, but we need to keep on injecting for most cases. And the funding is not always covered. It's covered for other diseases, but because radiation maculopathy overall is a rare event, there's no nice guidance saying we have to have funding for this. It's an individual thing. We in Liverpool can get it for most of our patients, but sometimes if your home hospital is elsewhere and perhaps far away, that can be a real difficulty. So there have been various trials showing that basically whatever you inject of these anti-VEGF drugs, and there are various ones on the market, it can lead to an improvement. Not all patients respond and some stop responding. That means that it's successful for a while, but then after a year or two, for reasons we don't know, it doesn't respond anymore. Biggest risk, other than being extremely uncomfortable, is that you can get an infection. Fortunately, that's rare. It's 1 in 2,000 infections. But the symptoms would be that you develop pain on day 1 or day 2 after the injection. That would be an emergency that needs to be seen straight away, really. Fortunately rare, but if it happens, it can be a serious side effect. All of the different anti-VEGF injections work, and some of them, some type is better than the other in some patients, but that's an individual thing, really. Funding for them is a major issue, and Eylea, and I come to that, is the one that's supposed to work a little bit longer, but unfortunately it's the most expensive one. So if we look at the individual drugs, Avastin, that's probably used most commonly, this is not a licensed drug for the eye, because for licensing, the drug company has to apply for funding. It's the same company that sells the more expensive drugs, so they will never apply for funding. But it is an anti-cancer drug that's available in every hospital, and some pharmacists are now specialized on dividing these big bottles into small injection bottles. Makes it quite cheap. So one injection from the drug cost only is about 10 to 100 pounds, depends on where you buy it from, and it works for about 6 weeks. There are two licensed drugs on the market. Lucentis, you may have heard of it, is licensed for other eye diseases, not for this particular indication, but for other eye diseases. It works something between 4 and 8 weeks, but you can see the price, £550. It's more expensive. And the last one is Eylea, again licensed for various eye diseases. The idea behind it is that it works longer, but it's also more expensive. And keep in mind, this is a chronic treatment, so something that needs 10, 20, 30 injections in some patients. And you can see that costs ramping up really, because there has never been a licensing issue for this. In most cases, we would use Avastin. There have been various trials comparing Avastin to the other drugs regarding safety and efficacy, and there's no difference. The difference is for the other diseases, it's not licensed at all. And because there's no licensed drug for radiation maculopathy, we still use it because it's definitely better than doing nothing. An alternative is steroid injection. You see that here. This is the tumor down in the eye, and this is a steroid pellet. This is called Ozurdex. So this is a pellet that releases the drug over a longer period of time. And it does work in radiation maculopathy. You can see here the swelling goes down, but you can see in the bottom picture, unfortunately, it will come back after a while as well. It does stop the leakage from blood vessels, and it works in some cases when the Avastin or the other injections fail. So it's our second line of treatment really. It works longer, which is a positive effect, but there are some negative effects as well. Again, it needs to be injected into the eye, and the needle is slightly bigger than the anti-VEGF needle, so it's a little bit more uncomfortable. It works only for approximately 3 months, and then back to square one, we need to continue to inject it. So it's an ongoing treatment again for most cases. What you get for sure is a cataract development. That means that the lens inside will fog up. Not a major drama because we can do cataract surgery, but it means another surgery, and in the meantime, when it's getting worse, your vision will get worse as well. And there are some patients called steroid responders. For reasons we're not quite sure about, they will develop a high pressure once steroid is injected into the eye. Now, that is not serious in a lot of cases, can be treated just with drops, but in few cases it can cause a problem. The risk is about 10% for some type of high pressure and about 1% of getting a serious problem for it. So it's something that can be a problem. This is why the steroid injection is the second choice regarding the treatment. And the funding is challenging for it. Again, the drugs, the cheapest one we can use, not licensed at all, is triamcinolone. That's your standard steroid you inject into a knee or something, so it's available in every hospital. It's not licensed for use in the eye, but again, before you just watch it and do nothing, I think it's ethically okay to use it because it's been used on millions of eyes for other diseases as well. Once you know it's working, usually one goes to Ozurdex, which is licensed for uveitis. And in a way, you can say that part of the causes behind the radiation maculopathy is uveitis, which means inflammation inside the eye, because part of it is inflammation from the dead tumor left in the eye. So in a way, I think one can justify that this actually is caused by uveitis, and you can use it. But it's a difficult discussion sometimes with the funding organizations for this. And you can see it works for 3 months, which is nice, longer than most of the anti-VEGF, but it's quite expensive as well. And finally, there's a top one on the market called Iluvien. This is a long-acting steroid. It works for 1.5 years, but it is a lot more expensive. It's £5,500 at the moment. It's again licensed for uveitis, but you have to have an artificial eye and you have to have some treatment before demonstrating that it responds to steroids. And we're now starting to treat the first patients with radiation maculopathy, but we don't have a long experience. There are some publications that it works, and we would try to do that, because imagine only one injection and you don't need an injection for a year and a half. That's great, but we're not quite there yet. But just to give you the picture what's under development at the moment. Now, sometimes we say, look, you do have radiation maculopathy, but treatment really doesn't make sense. When is that the case? Like in this case, there is radiation maculopathy, no doubt, but the tumor has affected the center, including the fovea. That means that the fovea and the center macula would have received 100% of the radiation dose. And that means there's a high risk of damaging all retinal cells in that area, not only the blood vessels. So that means that, unfortunately, the vision is very likely to be very low in the future. So it doesn't really make sense, so it's not fair to treat the maculopathy in between. So give you a couple injections, so a couple of weeks you notice what could be, and then the eye will get worse anyway. So in cases when the chances for a long-term good central vision are low, and these are tumors at your optic nerve head or at the macula and fovea, we usually would not recommend to do any active treatment, because these injections are a big burden on patients, they're expensive, and they have the risk of infection. So when it affects the fovea, or when there were high radiation doses to the central structures of the retina. And sometimes we see that the OCT scan gets better with the injection, but we asked the patient, they said, I haven't noticed any difference. So from our point of view, treatment makes only sense if the patient notices a benefit from the treatment. And we don't treat the pictures, we treat patients really. So it has to go hand in hand with something that you notice that will get better. If you do have other significant eye problems that interfere with your vision, it's no point doing then these injections for maculopathy. Or if you don't feel the benefit, if your other fellow eye is 100% good, whether the affected eye is 20% or 30%, in most cases doesn't have any influence on the quality of life. But going to a hospital, possibly far away, every 6 weeks for injection inside the eye, only makes sense if you feel the benefit of it on your quality of life, from my point of view. Finally, radiation optic neuropathy. What is this? This is the swelling of the optic disc, exclusively almost in patients with a tumor at the disc, and that's an acute swelling as a reaction to the radiotherapy, usually between 6 and 18 months after the treatment. And most patients would feel a visual acuity loss. So the vision gets out of a sudden a lot worse following the treatment. It can be treated. It responds a bit to steroid injections, and the swelling will settle without treatment as well. So if you just wait long enough, the swelling will go away again, but it will usually leave a long-term damage to the optic nerve head, that the vision will permanently be damaged. So it is controversial if treatment is of long-term benefit. At the moment, sometimes we discuss it with the patient that the long-term chances for a good outcome are not very high, but if you want to try it out, just try an injection out. It usually responds better to steroid treatment. The last treatment group is the proliferative radiation retinopathy. I show you this patient again who really walked through all the steps of radiation retinopathy to the proliferative stage. If you see something like that, that is in danger of losing the eye with hemorrhages, with a high pressure in the eye. Approximately 5% of patients will get it. It used to be more common if you treat larger tumors. Now that we know of many, many years of radiotherapy, if you have a very large tumor inside the eye, you've got a massive risk of developing these problems, and you have got virtually no chance of saving vision. We usually recommend to remove the eye and not undergo this active treatment, because you will run from one problem to another and to another, and at the end will be that proliferative radiation retinopathy. It may be asymptomatic in the beginning. When the vessels start to grow, you won't feel anything, but early hemorrhages may cause floaters in some patients. If it's just about to start, it requires urgent and intensive treatment. The aim is to save the eye. You're usually not fighting for good vision, but save the eye with some vision, hopefully. And the treatment is extensive laser plus or minus anti-VEGF treatment as well. In advanced cases like this one, you also need to do surgery inside the eye to remove the blood with surgery and the jelly, the vitreous. And this is the same patient after the treatment, quite a good outcome. The vision is low, but the eye could be saved over many years up to now with extensive laser scarring and the vitrectomy. So I'd like to thank you very much for your attention. If you do have any questions regarding this talk, this is my email address where you contact me regarding this talk. Thank you very much.